Hello and welcome to today's webinar featuring Orrin Devinsky. I'm Claire Cameron, Engagement Editor at Spectrum, the home for autism research, news and analysis. We'll begin the presentation in a moment, but first, please know that you can ask questions during today's presentation. We will field questions at the end. You can ask them at any point during the session. To ask a question, submit them via the chat window to the left of your screen. And as always, I'll note that if there are members of the media tuning in, you can only report information presented during this webinar if that material has already been published elsewhere, or if you have first obtained express written permission from the presenter. Professor Orrin Devinsky joins us today from New York, where he is professor at New York University. At NYU, Devinsky is the director of the Comprehensive Epilepsy Center and professor in the departments of neurology, neurosurgery, and psychiatry. Before joining the faculty at NYU, Devinsky studied at Harvard Medical School and completed a residency at New York Presbyterian Weill Cornell Medical Center and a fellowship at the National Institute of Health. His epilepsy research focuses include cannabidiol, autism, genetic epilepsies, sudden death in epilepsy, helpful behavioral changes, therapeutic electrical stimulation, quality of life, cognitive and behavioral issues, and surgical therapy. He is the principal investigator for the Northern American SUDEP Registry and for the SUDC Registry and Research Collaborative. He is on the executive committee of the SUDEP Institute and scientific advisory boards of the Epilepsy Foundation, DUP15Q Alliance, Tuberous Sclerosis Alliance, KCNQ2 Cure Alliance Foundation, International FOXG1 Foundation, KBG Foundation, and chairs the Lula Foundation CDKL5 Program of Excellence. He serves as a lead investigator for the Epidiolex, Dravet, and Lennox-Gastaut studies, and for the PTC Atuloran study in genetic epilepsies. He founded Finding a Cure for Epilepsy and Seizures, and co-founded the Epilepsy Therapy Project and epilepsy.com. Welcome, Professor Devinsky.
Thank you very much, Claire. It's my pleasure to provide an update on what we're learning about cannabis-based therapies for epilepsy and also for autism. So let me start out with some background. Cannabis has been around for a long time. Many of us know it by the name of marijuana. And I want to review a little bit about its use in medical indications, but to start out with a little bit more about its biology. So there are two main species of cannabis. Sativa is the first one for which we have historical information, and this was from China going back almost 12,000 years ago. And this strain of cannabis, or species, has a higher THC content than CBD, and I'll be getting into a little bit more about the THC and CBD and what they mean physiologically. The indica strain was first described in India more than 3,000 years ago, and it tends to have higher CBD levels than the sativa and can be more sedating. However, the reality is that these species have been interbred very, very heavily in the last 50 years, and many growers will label something as sativa or indica, but likely it is actually a mixture of the two of them. Cannabis chemistry is complex. There are the two compounds that will be the focus of my talk today, and actually CBD will be the main focus. But it's important to recognize that there are more than 500 different compounds that can be obtained from the various cannabis species. The two most important ones are tetrahydrocannabinol, or THC, which is the psychoactive ingredient in cannabis or marijuana that produces the high, but likely also offers some opportunities for medicinal purposes. And this system was discovered first, and the endogenous system, that is, the reason THC does cause psychoactivity in humans, is that it stimulates receptors in our brain for which our bodies make chemicals itself, natural compounds called endogenous cannabinoids that stimulate these receptors. The main one in the brain and central nervous system is the CB1, or cannabinoid 1 receptor, and the other receptor, the CB2 receptor, is primarily outside the brain and is mainly found on receptors of cells involved in immunology. The other major compound in cannabis, that is, if you took the average cannabis plant and found the two most abundant compounds, the two would be THC, which is psychoactive, and CBD, which is not psychoactive. The CBD does not bind at usual doses physiologically used in humans to either the CB1 or CB2 receptors. So it's a completely different mechanism of action, which is also consistent with the fact that it has no psychoactivity. The receptor we think may be most critical for the role in helping to treat epilepsy is the GPR55 receptor, but there are TRPV receptors, which also are likely involved in some of the anti-seizure and potentially other effects. And CBD also has effects on serotonin receptors, which may be related to some of the potential role it can have or may have in treating anxiety disorders. So this slide shows a cartoon under the structure column of THC on the top, CBD or cannabidiol in the middle, and CBDV or cannabidivarin on the bottom. I'm not going to spend a lot of time talking about CBDV here, but I will let you know it is a compound that is being investigated, and there is a trial that is just about to get underway in autism, not in epilepsy, but in autism, using CBDV to see if it can ameliorate some of the symptoms in autism. CBD has also been used in separate trials in epilepsy. So there's a lot going on here. One of the main things from the slide, and this is from a New England Journal review I did with Daniel Friedman, so you can find this there, is that these compounds bind to a lot of receptors. Yes, for THC, we think that CB1 receptor in the brain is the major way in which it works. For CBD, as I said, there are about 3 or 4 receptors that we think are the most important ones, but the GPR55 and TRPV receptors are leads in that group. And for CBDV, again, there are multiple receptors. So these are not simple drugs that act only on one receptor, but they have complex effects. So let's turn to the biology and the evolution of cannabis. There's a family, Cannabiceae, which has been around for more than 15 million years, and cannabis, which includes hemp plants and cannabis or marijuana, evolved at least 15 million years ago, while hops, which is used for brewing beer and other purposes, evolved about 6.5 million years ago, and they do share a parental or evolutionary background together. So one important question, and I think a really good one that many people have asked, is so why would a plant have 540 compounds? And the reason is it has these compounds for some reason, typically a reason that's helpful to it now. Some of them, which may be at very, very low concentrations, may be of no value now, but may have been helpful to an ancestor 2 million years ago or 5 million years ago. But whenever a plant makes a chemical, like THC or CBD, it takes part of the cellular energy and machinery to make that. And to make a chemical means it's not doing something else, growing, reproducing. So in evolution, there's always a cost benefit. And what we know about other plants is that they produce chemicals to combat infections from viruses, bacteria, funguses, to ward off attacks from insects, to prevent desiccation. The bottom line, and this should come to no surprise to anyone who's had biology, is that animals and plants evolve for their own benefit. There's no way that cannabis evolved over this period of time to help humans, at least certainly not prior to 50 or 100 years ago when we started to cultivate it quite seriously. So these compounds are there for the plant's benefit. And I'll get to that later because many people think that sometimes the plant mixes these things to help treat human disorders, and that's simply not the way evolution works. So the domestication goes back probably 10,000 years or more in Central Asia, and the early uses were for rope and cord due to the high fiber content in hemp and cannabis. It was used, we know, for religious reasons. Medicinal sources are documented going back to at least 1800 BCE and probably earlier. So again, it's been part of human medicine for 4,000 years. And of course, it's been used recreationally for a long time as well. So again, I just want to touch a little bit on artificial selection and what it does. And on the left, you see an English bulldog from the late 19th century, around 1890, that photograph is taken. And if you look at a much more recent picture of an English bulldog, there are many, many changes to the face and to the body. And indeed, these bulldogs now can only be bred artificially. They need to be artificially inseminated and born via a cesarean section type of procedure. So artificial selection in 100 years can dramatically change a species. And if you want to think about how dramatic change can happen over thousands of years, take a look at the evolution of maize or corn. The wild ancestor, teosintite, back 7,000 years ago was barely the size of a pinky, and 50 of these probably provided about the same amount of calories as a modern ear of corn does that we get today. So this is something where humans took it and then took the largest one, took the one with the most sugar or starch content, and then kept selectively breeding over time. And so most plants and animals that we consume today in the world are the products of artificial selection, man-made selection. And I say this because we have the sense that things we eat, an ear of corn, something grown on a fruit tree, a lemon, that these are natural. But if you look at a picture of a lemon from 100 years ago, the rind is 2 times or sometimes 3 times thicker. What we're eating today is not a natural product. It is a product of human engineering, not by introducing genes, but by specifically selecting genes. So what else isn't natural? And one of the things that's not fully natural is us. In the last 12,000 years, the human species has changed. Our skulls are thinner, our jaws are smaller, and one of the leading theories why humans have to frequently have wisdom teeth removed is that as children, we don't chew the food we were evolved to chew. We have sugar, we have white flour, white rice, things that have been heavily processed that don't have fiber in them. And so children are not chewing the amount they used to, and essentially their jaw is not growing to the size that it was meant to grow. And what's the problem? Well, with smaller jaws, the teeth are following their evolutionary path, and when the wisdom teeth come in, there's not enough room in the smaller jaw. Milk tolerance. Prior to 5,000 years ago, when humans first started domesticating goats and cows, prior to that, no mammal for 200 million years was tolerant to milk after weaning from their mother's breast. Now, large populations of humans, many from European descent, but some in Africa, some in the Middle East, have developed milk tolerance due to genetic adaptations. And then there are many genetic adaptations that have occurred recently that give rise to a large number of anemias for people in Africa and the Mediterranean region, for example, to malaria, but also to other disorders. And we're left in many ways in today's world with most of the chronic problems are not problems that afflicted humankind really prior to 250 years ago. Obesity, diabetes, cancer, dementia, hypertension, back pain, constipation, and many other problems seem to be very, very recent issues. People have studied hunter-gatherer groups and native indigenous groups, whether they were New Zealand Islanders or Native Americans. These disorders were extremely rare in those populations. So I do this introduction on evolution because there's a strong feeling among many people that if it's natural, it's good. But that's not right. So this picture is a picture of a pufferfish known in the sushi world as fugu, and it has a toxin called tetrodotoxin. A absolutely minuscule amount of this toxin, well less than a milligram, will kill multiple people. So again, just because something's natural, like poison ivy, does not mean it's good for you. And then I think many people worry about genetics in the wrong way. We worry about genetically modified organisms. If a rice is genetically modified to increase the amount of micronutrients or resist pests, I would consider that a wonderful thing. I think we've saved hundreds of millions of lives through genetically modified rice and other plants. In addition, we've saved our environment thousands and thousands of tons of pesticide use. So again, it's always a risk benefit when you think about what we're doing and how we influence our body and our environment. So now I'm going to turn back to cannabis and just try to start out by dispelling one common myth I hear a lot about. And that is something I referred to earlier, that the cannabis plant is mixing products together to give a natural blend of things that are good for us. And in the epilepsy community, there are many parents who hold that CBD alone, for example, won't control a child's epilepsy, but if you add a little THC or a moderate amount of THC, that it will work. So where does that idea come from? Well, the entourage effect is something originally described by the Israeli group, Ben Shabbat, and most importantly, Raphael Mechoulam, who first isolated and synthesized both THC and CBD. And they discovered that there's a compound, it's a longer name, but I'm going to call it 2-AG. It's in your brain, it's in my brain, and it stimulates that CB1 receptor. It stimulates it. It's an agonist, it's called. So what they studied was that there are esters of this compound, esters of 2-AG, that themselves don't bind to the receptor. But if they're present together with 2-AG, those esters increase the action or the effectiveness of 2-AG on the CB1 receptor. So they referred to that, I think very appropriately, by the term the entourage effect. When the entourage is present, you get this synergistic effect. When only 2-AG is present, you stimulate the receptor to a certain amount. When you have only the esters present, you don't stimulate the receptor at all. So this has now been taken, this entourage effect, and translated, or more accurately, I would say, lost in translation, to mean that CBD and THC act synergistically. Now that may be true, and if they do act synergistically, we would have to look at which specific indication, disorder, experimental model we think they might act synergistically and study that. With regards to epilepsy, I can tell you I'm aware of no animal or slice data or human data other than individual people saying it worked, which is dangerous because individual people have said many things have worked, and the vast majority of the time when good trials are carefully done scientifically, it turns out they actually didn't work, that it could have been coincidence, could have been a placebo effect, could have been another thing they were doing at that time. So again, getting back to that earlier slide, cannabis did not evolve and put compounds together to help human epilepsy. It was done to improve the plant's fitness. But you can go on websites, but such as the one I have here, Your Brain on Bliss, and it says, new research confirms what has long been thought. CBD, in addition to other entourage cannabinoids like THC, is far superior medically than pure CBD. Now, this is just raw, this is just unscientific. I could say CBD is more effective without THC, and it would have equal merit. It just hasn't been studied, so no one knows. People are allowed to give their opinion, but they should clearly state, this is my opinion, what I've seen in treating some people. The problem is the best doctors in the world, at the best medical schools, when they have made statements like this based on their experience, they've often been wrong. So doctors can be wrong, patients can be wrong, parents can be wrong, and that's why we do science, because we can all be wrong. So this is the first of a series of papers. There were 3 now that have been published, looking at cannabidiol for drug-resistant epilepsy types. And the 2 syndromes that have been studied to date with solid scientific evidence are Dravet syndrome and Lennox-Gastaut syndrome. It's important to recognize that these are relatively rare epilepsy syndromes, representing well less than 5% of all epilepsy patients in the United States or in the world. So in this study, we gave cannabidiol at a relatively high dose of 20 milligrams per kilogram per day divided in 2 doses. Took about 2 weeks to build the levels up, and then patients were either on a sugar pill, or sugar solution, I should say, or cannabidiol for a period of 3 months. And the important thing is that during the treatment period, the reduction in seizures, you can see, was a percent change of almost 39% versus 13% in the placebo-treated group. So a substantial difference, which did meet statistical significance at a 0.01 level. Traditionally, a 0.05 level is considered statistically significant. So there have been additional studies looking at CBD as well. And I'm going to summarize these 2 studies here. Actually, the second one was published recently in the New England Journal of Medicine as well. In the first trial, led by Dr. Elizabeth Thiel, patients were 2 to 55 years of age. They enrolled a little over 170 patients. Only a single dose was used, 20 milligrams per kilogram per day, and this was compared to a placebo. And again, neither the investigators, nor the parents, or the patients, or the study personnel were aware of who was in the placebo group and who was in the treatment group. The median percentage of reduction in drop seizures, which is the most severe type of seizures in these patients, in the CBD arm was 44% versus 22% in the placebo arm. So again, a statistically significant difference. And then a second study was done, which I was involved with leading, and this was the second LGS trial, same age range, a slightly larger cohort. And the important difference here is we compared 2 doses. So patients were randomized to one of 3 groups. Either they got 20 milligrams per kilogram per day of the CBD, they received 10 milligrams per kilogram per day of the CBD, or they received the placebo. And for the 20 milligram per kilogram per day group, the median reduction in drop seizures was 42% versus 17% from placebo, so a 25% difference and a highly statistically significant difference. And in the 10 milligram per kilogram per day dose, the median reduction was 20%, which again reached statistical significance. And you can see this p-value or statistical significance is even greater than the Lennox-Gastaut difference, mainly because it was a larger group. So that difference showed up more significant. There have been other trials of CBD and CBDV in epilepsy and other disorders. So I'm going to spend a few minutes here and summarize the high-level findings from these groups. So one study was done in focal epilepsy. This was done by a different company than the Epidiolex company, and they used a transdermal CBD. And unlike the studies we had done earlier that I reviewed on Dravet syndrome and Lennox-Gastaut syndrome, this study used a synthetic CBD, and it was applied across the skin transdermally, which is actually a very effective way to introduce CBD into the blood system and get it into the brain. 182 patients were studied, and unfortunately, there was no difference between the placebo and the treatment groups. So this was unfortunately a study that did not have a positive outcome. There was another trial that looked at CBDV. Now, keep in mind, if you remember that earlier slide that compared all the receptors that CBD, THC, and CBDV work at, you would notice that CBDV and CBD are really quite different in what they do. And I'm going to go back quickly and just peek at that slide. So you can see on the bottom there, CBDV works at the TRPA1, the M8, the V4, the V1 to 3, and the DAG-L alpha, whereas THC has a very, very different profile. A couple of things overlap, perhaps a couple more overlap, the TRPA1, the TRPV1 to 3, the TRPM8, and the TRPV4. Those are all the same. The DAG-L alpha is only present in CBDV, and many, many effects of CBD, including what we think is extremely important, the GPR55 receptor, and potentially for anxiety effects, those 5-HT or serotonin receptors. The CBDV does not work on any of those receptors. So keep in mind, this is a different compound than CBD. But in this trial for focal epilepsy, the CBDV was equal or not differentiated anyway from placebo by the statistical test. So we now have two trials in focal epilepsy that show no benefit from either CBD or CBDV. Is the jury done? Probably not. I think we probably need more studies to conclude it doesn't work. But the fear is with two negative studies on these two compounds, which have many overlapping properties, but some different, is that this may turn out not to be a terribly effective treatment for focal epilepsy. And to be honest, may not be effective at all. We need more data. I should also say, as completely personal anecdote, and I wouldn't take this as anything close to scientific data, but only a clinician's impression. I'm a practicing epilepsy specialist in both New York and New Jersey, and participate in both of those states' medical marijuana programs certified through the Department of Health, and have treated many, many patients with focal epilepsy with both CBD and THC. And I must say the results have not been impressive. I have had very, very few patients in whom I really think I've seen anything close to a clinically meaningful improvement. And that would be well under 10% of patients. And that could easily be due to some combination of chance that this epilepsy just got better for a period of time, a placebo response, or expectation. So it's hard to know, but right now, the role of CBD and CBDV, and from my experience, THC in focal epilepsy has not been promising. Fragile X is a rare disorder. It is one of the more common genetic forms of autism and is also a cause of epilepsy. But this is a trial that was done not for epilepsy. This was a trial done by that company Zynerba with a synthetic CBD, and they enrolled 20 patients in an open label trial. Now keep in mind, open label trials means that the doctor knows what they're giving, the family, patient, if they're cognitively aware, know what they're getting, and the primary effects that they were looking for were on anxiety and behavior. And the transdermal CBD was more effective than placebo in a very, or I should say from baseline where they were before the study, in a very significant way. But what the slide should say is that the placebo effect could not really be factored in because it was an open label study and the family members knew what they were receiving for their child. Now, parenthetically, it's important to recognize that the placebo effect is real. I wrote an editorial in the New York Times about 4 or 5 years ago with my colleague Dan Friedman, and we noted that the placebo effect is one of the dangers in using a drug or compound where there is a tremendous amount of interest, where there is a tremendous amount of enthusiasm. And I must say, having been in medicine now for 30 years, I have never seen the enthusiasm for any compound or any drug, natural or otherwise, as I have for CBD and cannabis products. So when we wrote that editorial, many of the comments that came in were essentially saying, we're crazy, we don't know what we're talking about. There is no such thing as a placebo response in epilepsy. How could a kid stop having seizures to a placebo response? And I completely sympathize and understand the feelings behind those statements that were made largely by parents, I believe. But the reality is the placebo effect is real. And what is shocking, and I didn't know until I started in this cannabis area of medical research, is that whereas in the average epilepsy trial, if you have a drug that a major pharmaceutical company or small one is interested in treating people with epilepsy, and you give it to a patient, and there's a placebo and an active agent, the placebo response, the reduction in seizures, will be, if there was a responder rate saying the drug works by reducing seizures by 50%, at least 10 to 12%, sometimes higher, of the placebo group will have that greater than 50% response. So that's a placebo response rate of 10 to 12%. And it's a real problem in trials because if the placebo response rate is higher, like 25%, which it can be in trials, and the true drug really works at a 30% rate, it will appear that the drug is completely ineffective. Now, I say all this because what is not intuitive is that the placebo response rate in pediatric studies is almost twice the placebo response rate when adults are tested. And this is very counterintuitive for me. I would have thought the placebo response rate would have been much higher in adults who are much more susceptible to suggestion, whereas the children, in some cases, are either intellectually impaired and don't even know, or they don't even know that they're in a double-blind study. So it's remarkable that a lot of these ratings are done by parents, and likely it's the parents who are the biased, and they may be more biased about their patients than they are about themselves. So it does speak to the need for placebo studies. And as I showed you, and I'll go back to again for a moment because I think it is worthwhile, in the two Lennox-Gastaut trials with the three different arms compared to placebo, the placebo response was 17%, 17%, and 22%. Those are big percent reductions in seizures, and shows that the placebo response is real. It comes out in every study, whether it's psychiatry, heart disease in 70-year-olds, cholesterol reduction, blood pressure reduction. The placebo response is ubiquitous. So I'm going to finish up on a couple of other studies that were done in schizophrenia. There's one study on 88 patients where CBD reduced positive symptoms like hallucinations and agitation and overall rating of improvement. But in another study in schizophrenia of 36 patients, CBD was not effective. So again, we're in the early days, and what I would strongly advocate and argue for throughout is that we need more data on specific compounds or combination of compounds. I'm open to what is tried and in whom it's tried, but it should be tried in a scientific way so we can learn from it. If, for example, CBD has no role in focal epilepsy, then let's not give it to people with focal epilepsy because CBD has side effects. Those side effects are real. And in the double-blind studies, over placebo, it caused tiredness, it caused dizziness, it caused sedation, it caused nausea, diarrhea, weight loss, and especially in people who are on valproic acid or Depakote, it caused significant elevations in liver function tests, meaning the liver was being impaired in its ability to do its normal job. So I want to turn now briefly to autism and the concept of science versus religion and data versus belief. And I say this because there's clearly a lot of use of cannabis-based products in the autism community. I'm very open to it, and I'm very open to studies being done. And I've have many patients with epilepsy who have comorbid autism, and the families relate that in some cases the CBD or CBD with THC hasn't done much to control the epilepsy, but it's helped the child in their behavior, to be more calm, to sleep better, and to function better. So I do think it deserves attention in autism, and I do believe it'll get that. I'm involved in several trials along those lines right now. So in this slide, I just show you what happened about 2 months ago or so when I went to the National Library of Medicine, which any of you can do by just Googling and finding the site PubMed, P-U-B-M-E-D, and I typed in autism and cannabidiol, and I got 2 articles. I typed in autism and THC, and I got 2 articles. I typed in autism, and I got over 41,000 articles. So the ratio of articles on autism to those on autism and CBD or THC is a ratio of about 10,000 to 1. It's a huge ratio. There's a lot more scientific data, like literally 10,000 times as much about autism than there is about using these drugs in autism. But when you go to Google and you type in the word autism and CBD, you get 428,000 hits. When you type in autism and THC, you get 380,000 hits. And when you type in autism, you get 121 million hits, a ratio of about 150 to 1. So the interest among the lay community is about 60, or I should say 600 times greater than the scientific data right now. And it just keep in mind the amount of enthusiasm among parents, among many people to use cannabis products in autism is enormous. The scientific evidence is minuscule. So, as I said, just briefly reviewing some of the epilepsy trials, since epilepsy occurs in at least 25% of people with autism spectrum disorders over the course of their lifetime, the results that we found on CBD reducing seizures and Dravet and Lennox-Gastaut syndromes may be of benefit, but the most common autism-related epilepsies are focal epilepsy, and it failed in 2 trials, CBD and CBDV, and it has not yet been studied in generalized epilepsy, another relatively common form after focal epilepsy in autism patients. So medical marijuana for autism, medical marijuana itself, not explicitly for autism, is approved in most states for medical reasons. One of the issues that we face right now is that there are many different products, potentially of different quality. Different states have different quality control. And then the batch-to-batch consistency, and even products, they may just say, this strain is no longer available, we don't carry it anymore. Or this ratio of 2-to-1 of CBD to THC, we had that, but now we only have a 1-to-1 or a 10-to-1. And so that's a real problem if people are doing well or developing new side effects and people want to go back to the old strain or the prior formulation, it may simply not be there. With regards to THC, I think we should be humble. The rule of science is about what we don't know. In science, we need to stay humble and we must admit we don't know, despite times where we have a good amount of evidence. We can say we have a good amount of evidence and this is what we think, but we never know 100%. And there are so many times where the evidence appeared compelling, but it turned out there was an unintended consequence or an actual opposite effect. And the examples for that are essentially innumerable. And again, I just want to pause on this because so many people it's a religious belief that THC or CBD is going to be helpful for my child with autism. But keep in mind, vitamin E, when the women's health study was done through Harvard Medical School and School of Public Health at Harvard, it looked like nurses who took vitamin E supplements had lower cancer rates and lower rates of cardiovascular disease, which is great. And many, many Americans bought vitamin E supplements and took them. It's an antioxidant. What could be wrong with an antioxidant? And then eventually studies were done and specifically looked in a prospective, randomized way of people who took vitamin E supplements versus those who don't. And many of those studies found no benefit from vitamin E, and some clearly showed elevated rates of cancer, for example, colon cancer, and some found elevated rates of some cardiovascular disease. And in hindsight, it's not surprising. Vitamin E is not natural to be taken in large quantities. Vitamin E is an antioxidant, but our bodies were created to have both oxidants and antioxidants in a balance. And the oxidants serve as a fire alarm, like a smoke detector system for our bodies. And by taking large amounts of vitamin E, we disable the cell's ability to recognize certain oxidative stresses and thereby heal itself. And so we've taken away some of our body's natural abilities to help itself. Another example I'm fond of, which can still be debated, but I believe this is true, that in the 1960s and 50s, the American medicine establishment and dietary establishment told Americans that fats are bad. First it was all fats, then it was saturated fats. But the truth is the data was really weak. It was based on total cholesterol, then it was based on low density lipoproteins, LDL cholesterol subfraction. And now, as we get more data, it turns out that eating saturated fat, whether it's from palm or coconut oil, or from butter or animal fat sources, it actually lowers triglycerides, it raises HDL, the good cholesterol, and the fraction of the LDL that it raises is probably the healthy fraction, while the smaller dense fraction doesn't change much. In addition, literally in the 1960s, Americans were told to eat sugary snacks as healthy snacks, to eat vast amounts of carbohydrates, and the result is an obesity and diabetes epidemic. Now, all the doctors and dietitians who recommended high carbohydrate, low fat diets meant all the best. It just turns out, I think, unfortunately, in a societal way, they were wrong. So the point of this is we need trials, we need data. And for THC, to give it to young kids, I think if it's a treatment of last resort, I have done that myself and been okay doing it, watching those children closely. But I have to tell you, it's not something I like. I wish I had more safety data. I wish I had more data that it works. And that's what we need to get in the coming time. So what data do we have on CBD or THC in autism populations? There are some mouse studies that have been done that have had some positive findings. I mentioned before there was the Zynerba study of the synthetic CBD patch to treat Fragile X. It was a small group of individuals who were treated. It was open label, which means we have no idea what the placebo response rate was at in that group. But there were improvements in social avoidance, in temper tantrums, in repetitive movements, and in hyperactivity. But at this time for autism, the anecdotal evidence is unlimited, and the clinical trial data is absolutely tiny. So I will start to finish up here, and this is a slide taken from one of the Autism Science Foundation websites, and you can see all the things in the middle: chelation, secretin, Lupton, hyperbaric oxygen therapy, gluten-free diet, casein-free diet, stem cells, antifungals, vitamins, camel milk, nicotine, transcranial magnetic stimulation, dolphin interactions, and prisms that have been reported to be helpful in children with autism, and for which there is no scientific data, and in many cases now convincing trials to show that these therapies are not effective in autism. So the pictures on the left are a beautiful, clean highway with trees on the side and a lovely paved road and white lines in the middle. And I would say that's how most people view science. People in lab coats, in clean labs, doing wonderful experiments and informing us and giving us technologies from iPhones and computers to new medications. But I would argue that science looks like the road on the right. It is littered with failed trials. It is littered with ideas that the smartest scientists and the smartest doctors thought were absolutely correct, that over time proved incorrect. And the slide on the bottom right is a picture of a leech and a bleeding therapy, which is still done in some parts of the world. And in the 1700s and 1800s throughout Europe, was often a treatment of choice, together with cupping and other forms of bleeding and purgatives. But doctors undoubtedly in those years did more harm than good. And this is our goal now, to make sure that we are always careful to first do no harm and to be informed by hard evidence. So where do we go? We need scientific data. We need it soon, because there are so many individuals using these products for many indications. I have no doubt that it's probably truly helping many people in many ways. But I think we all fall victim to what we see is all there is. We believe what we see, we believe what we hear, we believe a friend's child did amazingly well with something, and it becomes an infectious belief. And just because everyone thinks the world is flat, or everyone thinks that the sun revolves around the earth, which is what most of humans believed at different points in time, and these were very intelligent people who had the same brain sizes and brain capacities we do, we can fall victim to the same illusions and same misconceptions. So again, my biggest message is we need more scientific data, and until then, we just should act carefully, compassionately, and always with an idea to do no harm. Thank you very much.
Thank you very much, Dr. Devinsky. We do have some time for some questions, and we have had quite a few come in, so bear with me, and if your question does not get answered, then I will forward them on by email to Dr. Devinsky after the end of this presentation. One of the ones that we had come in via email before the presentation actually began was, is there any further information that you can give on Epidiolex in terms of its when it might become available, and also on the possible schedule change for marijuana as a result?
So those are great questions. My understanding, and this is secondhand, is that currently either it's about to undergo or talks are already undergoing between the FDA and the DEA to reschedule CBD for Epidiolex, because as a Schedule I drug, which I think is a terrible scheduling and shouldn't have been there 10 years ago, but certainly shouldn't be there now, it'll hopefully be a Schedule 4 or 5. I don't know. I'm certainly not involved with this process. I hope that happens in the next 2 months or 3 months, and I hope that Epidiolex makes it to pharmacies by the end of this year or very early into the next year. But again, I think nobody fully knows the answer to those questions right now.
Another question about Epidiolex. What are your thoughts on Epidiolex as it relates to autism behaviors? And is it possible to be used as a replacement for CBD or in addition to?
So Epidiolex, I should point out, is 99% CBD. So what Epidiolex is a CBD preparation, 99% CBD, with 1% other cannabinoids that are all at extremely low concentrations. So CBDV, THC, terpenes, other cannabinoids are present, but cumulatively they all represent less than 1% of Epidiolex. So Epidiolex is basically a natural form of CBD derived from cannabis sativa plants. I do believe Epidiolex, or the equivalent other products of CBD, which could be made by other companies as well, should be assessed in autism. That one study I referred to was a small study. It was open label, but it certainly gave a promising signal that CBD may be helpful in helping to improve some behaviors in individuals with autism. But that small open label study does not begin to come close to the level of scientific evidence that we need. And I do believe good controlled placebo randomized studies will be underway soon.
Another question was, Lennox-Gastaut syndrome patients have both focal and generalized seizures, and the trial of CBD in LGS did look at total seizures. Did the CBD have any effect on focal seizures associated with Lennox-Gastaut?
That's a very good question, and I need to go back. So the issue with the Lennox-Gastaut trial is it's hard to tease all these out. We decided before we started, and I think we did the right thing, to only count drop seizures or seizures that would be associated with a drop. So that's one of the more severe seizure types. So essentially what we counted in the trial during the randomized phase of the Lennox-Gastaut trials was either tonic seizures, which would have caused a fall if the patient was standing or they did cause a fall, atonic seizures where the individual lost motor tone, and again, if they were standing, would have fallen, or tonic-clonic convulsive seizures. Those were the only seizures that went into the primary outcome measure, and those were the seizures that were significantly reduced in individuals with Lennox-Gastaut syndrome. Whoever asked that question is knowledgeable. They're absolutely right. Focal seizures can occur and do occur in people with Lennox-Gastaut syndrome. But number one, they're harder to count. So if someone with Lennox-Gastaut, who typically is someone who has intellectual disabilities, stares into space for 20 seconds, it can be really hard for an expert epilepsy doctor or a parent to reliably differentiate a period of inattention from a seizure or many other phenomena. So although we counted those and put them into the total seizure count, we really focused on the primary outcome measures, the drop seizures and tonic-clonic seizures. And so the answer is I don't think we have enough data to say whether it worked on focal seizures, but my suspicion is probably not. If we took out that group of focal seizures, I don't have that specific data, and I'm not even sure we could really do that accurately. My suspicion is it probably didn't do so well in that seizure type, although I say that without great confidence.
Another question we have is, what are your thoughts on pharmacogenomic testing, specifically a buccal swab, for an individual's genetic responses for prescription drugs used to treat the behavioral symptoms of autism, including epileptic seizures, and for their responses to medical cannabinoids used in CBD and medical cannabis products, including drug-to-drug interactions?
Again, a very good question. There are a number of companies that now, through a sample of saliva or a skin swab from the inside of the mouth, can do a gene test and tell you what enzymes are in your liver that metabolize different drugs. And so we know some drugs are metabolized by certain isoenzymes in the liver, and based on the genes you have, you may be a rapid metabolizer, I may be a slow metabolizer, and someone else may be an average metabolizer. And so those tests can inform a physician or a parent or patient that if you go, let's just say, on risperidone to treat autism behaviors, that if you're a rapid metabolizer, your child or your adult or you may need a higher dose than the average person because you go through that medication more rapidly. Now, many of us in clinical practice, and I can tell you all of Europe does this much more than we do in Canada and Australia, is the feeling is in those countries, apart from never mind getting gene testing, they don't even do drug testing that much, which we do a lot of here. The idea being if you have seizures and epilepsy or agitated behavior and autism, if the goal is to control seizures or agitation, start with the medication, introduce it gradually, increase it slowly to the point at which you get a beneficial therapeutic effect or you get a side effect. And if you do that, then the only conceivable advantage of these gene tests would be to tell you in a rapid metabolizer, you can start at a slightly higher dose and push the dose escalation a little faster. What it doesn't tell you, however, is that what the receptors that individual, what their genes are in their brain. So it may turn out that I'm a rapid metabolizer for risperidone, which would predict that I need a high dose. But what those gene tests don't tell you is my dopamine 2 receptors in my limbic system may be extraordinarily sensitive to risperidone. So the truth is, I'm actually need a low dose. And so that's always the problem with a little bit of information. Kahneman, who won the Nobel Prize in psychology, but actually I should say in economics, but he was a psychologist, coined that phrase, what you see is all there is. So people get a little bit of data, which I would say is, in the case of these enzyme tests of hepatic metabolism, maybe 10% of the picture, maybe 30% or 50% of the picture, and then they use that as the whole picture, and that's dangerous. I think ultimately you need to take care of people, not their blood tests. I think those tests can be helpful, but to a very limited way.
Another question we have, it's been observed in autistic patients who demonstrate an increased prevalence of subclinical epileptiform discharges that addressing these with anti-epileptic drugs can offer some benefit. Would it be reasonable to posit that one of the benefits of the use of CBD is that it can assist in ameliorating such SEDs, and that this is a physiological conduit for its benefit in not only addressing bona fide seizures, but also supporting cognitive functional status, which can be adversely affected by SEDs?
Yeah, so I think when SEDs,
the subclinical epileptic
discharges. Got it. So it's a good question again. So I think one of the challenges, if we have a person with autism and epilepsy or just epilepsy, and we give them CBD and they do benefit and their seizures are reduced, let's say 50% or 25%, and their cognition gets better, the question is that effect from number one, the reduction in seizures? Most people with epilepsy, when you reduce their seizures, they do better cognitively. Could it be an effect on the CBD on cognitive function independent of seizures or subclinical epileptiform discharges? Yes. Or could it be an effect on subclinical discharges? That's possible as well. There have been no studies to date that I'm aware of that CBD is effective in reducing epileptiform or subclinical EEG waves in people with epilepsy. So that's more speculative as a mechanism, but they're all possible, and I think we need more data.
Are there any studies that you know of studying the effects of the side effects of CBD in adults and autistic adults in particular?
In autistic adults. So From the Lennox-Gastaut trials, we did enroll people up to age 55 in both of those trials. So we do have a good bit of information on adults treated with CBD. In addition, this isn't pure CBD, but the medication that GW Pharma has had on the market for over a decade, I believe, called Sativex. Sativex is used to treat spasms in multiple sclerosis, and that's primarily an adult population who has received that, and it's 50% CBD and 50% THC. So I think the side effect profile of CBD in adults overall is fairly well defined and is somewhat similar to children. I think there's a little bit less diarrhea in adults in my experience, but it's still possible. But in the adult autism population, I think we need more data for that specific population. But it's a good question, but I would imagine it's going to be somewhat similar to what I presented.
Are you concerned at all about off-label prescribing for Epidiolex?
So I think I'm not concerned. I think medicine and doctors have always prescribed medicines off-label. Gabapentin was approved for epilepsy, but was quickly recognized by many doctors and patients to be helpful in pain syndromes. And now, whatever it's been 20 years after it came out, I would say 95% of the prescriptions are probably in the pain realm and not for the epilepsy. So that off-label use ended up being a good use. I think for Epidiolex, what will be the limiting factor, and people need to be aware of it, is that I don't have any idea what the pricing will be, but it's a new drug, and I know the company spent a large amount of money in the clinical trial phase, and I imagine it's going to be a relatively expensive drug. So I think if I was an insurance company, and I'm just making up a number, this drug cost $15,000 or $30,000 a year. I have no idea what it'll be. But if I was going to pay for that, I would want to make sure I'm paying for it for something for which there's proof that it works. So I think that people who have children with autism without Lennox-Gastaut or without Dravet syndrome, it's not the doctor like myself. I can write Epidiolex prescriptions, but they may get the denial from their insurance company, who may say you can get it, but you're going to have to pay full price.
And just coming to the end now, so these are the last questions that we're going to have time for today. Is there any data you know of on the effect of either THC or CBD with migraine, which is a common co-occurrence with autism?
Again, a great question, and an area for which I think pain is going to be one of the places I think you'll see a lot of research going on for both CBD and THC. Migraine is clearly one of the more common and chronic and prevalent severe pain syndromes in the United States and worldwide. So I think there are anecdotal reports of benefit, but scientific evidence is lacking at this time.
Are you concerned about using CBD with any other anti-epileptic drug?
I'm not concerned, but I think people should be aware there are drug interactions. CBD is a drug. And the two most prominent interactions are that for individuals with epilepsy who are already taking clobazam, which goes by, in America, the brand name Onfi, that there's an active metabolite, the N-desmethyl metabolite of clobazam, and that metabolite is biologically active, probably both in seizure control and in side effects like sedation. And if you take CBD, the levels of that metabolite can go up 2 or 3-fold. That's by 200% or more. So that can lead to side effects. And if people are on Depakote or valproic acid or Depakine or divalproix, all different names for the compound valproate, you can get elevations in the liver function tests, which at some point could be dangerous for some people. So again, I think it is important that anyone using CBD do it with a physician who's knowledgeable about it.
Okay, I'm afraid that that's all that we have time for. As I say, if your question didn't get asked, then I will be forwarding on to Dr. Devinsky. A complete replay of the presentation will be available on the Spectrum News site in a couple of days. This webinar is part of an ongoing series, so please check our site for upcoming talks to be announced soon and video archives of previous webinars. If you have a question following on from this webinar, please leave it in the comments section on the page on our site. We will send them on. And thank you again, Professor Devinsky, and thank you all for tuning in.
My pleasure. Thank you, Claire.
Thank you.